I'm Vasilis Babalieros. I'm one of the interventional cardiologists at Emory Hospital.
I'm Vino Tharani. I'm one of the cardiac surgeons at Emory University.
What is the concept of minimalist TAVR? Philosophically, the idea of doing transcatheter valve replacement was supposed to be very similar to coronary stent implantation, with a patient done in a cath lab hybrid room or maybe even an OR hybrid room, but without all the extra resources that you would need for open heart surgery, like a bypass machine, transesophageal echo, full general anesthesia, bladder catheterization, such as a Foley catheter or a Swan-Ganz catheter.
Right, Swan and arterial line catheters.
So really sort of the minimal equipment you would need and the minimal personnel and resources that would result in a successful and safe implant.
So what type of patient is a good patient for a minimalist transcatheter valve replacement? I would say that almost everybody who is a transfemoral candidate should be evaluated for the minimalist transcatheter valve replacement. There are some patients, specifically those that have nice large arteries, those are not super obese. We're talking about those that are less than maybe 150 kilograms. Those that have access to us to be able to perclose their arteries would be good patients also for a minimalist transfemoral transcatheter valve replacement. When I think of more of who's a good candidate, I really think of it's a very large majority are good candidates, except there are a few patient criteria that would actually shy you away from a minimalist TAVR. And those include those patients that have potentially a low hanging coronary, a left or a right, where you might require cardiopulmonary bypass support in case you get into problems, or that may require stenting during that cardiopulmonary bypass support. Another patient population you would think of are those patients that are, like I mentioned, morbidly obese, where you would have potential difficulty closing the femoral artery after puncture, are the ones that I think of. Vasilis, what other patient populations would you start thinking of that aren't categories for minimalist TAVR? Because otherwise, all patients should be categorized for the minimalist transfemoral valve replacement.
So I agree with you, Vino. I think that if you're going to do a transfemoral TAVR, that you should be evaluated potentially for a minimalist approach. What we're looking for in this type of approach is doing more straightforward patients. And I think you've alluded to, very obese patients with tricky vascular access probably are not great ones. In other words,
right.
If you anticipate that you might need surgical backup or surgical
cut down maybe sometimes. Right.
Cut down or access, or even to change from a transfemoral to a transapical, those probably aren't ideal patients.
Right.
We also have a few patients that have developmental delays that are not good for doing conscious sedation. The patient has to be somewhat cooperative. I think patients with advanced dementia tend to fall in that category as well.
That's
and
right.
Sometimes we have a few patients with chronic pain that even to lay down for 30 minutes or 40 minutes on the cath lab table.
It's very difficult for them.
Absolutely.
That's right.
And those are the type of patients that you would say, you know what, we're just going to put this patient to sleep and get to work. But for, I would say, the vast majority of patients that don't fall in that category, that can breathe well, laying flat, and be cooperative, they do quite well.
Absolutely. And one of the questions I get asked a lot also are severe COPD patients, and that are getting transfemorals. And I actually think that that's not a bad population for transfemoral valves in the cath lab in the minimalist technique, because they don't get intubated. Their major problem, and these are, again, patients that can lay down flat, but their major problem that we worry about is getting them off the ventilator and with general anesthesia. And so those patients, interestingly enough, the severe COPDs actually tolerate minimalist TAVR very well. So that's the patient population that I get asked about a lot. Should we do them? And actually, that's a great patient population to do that can tolerate minimalist transfemoral valves.
I agree with that.
Great.
How can we compare a little bit conscious sedation in the cath lab versus MAC, or even something one step heavier like general anesthesia? Certainly the level of consciousness, what we're talking about, is much deeper with general anesthesia, and it's a gray zone from conscious sedation all the way down. What we are looking at is not putting the patient in the deepest level of blocking consciousness, but to have them awake and be able to interact during the case. I think there are a lot of advantages to that. One thing that you and I have talked about a lot is evaluation of stroke.
That's right.
Right now, it's a very important topic. We have some protection devices that ultimately might help solve the problem, but until now, we don't have the ability to to mitigate completely or to treat
Or even evaluate.
or
Yeah.
to evaluate when these happen. When the patient's under general anesthesia, by the time they wake up and extubate, you're several hours down, and the window of treating these patients is much smaller. And I think one advantage of doing conscious sedation is you can see on table if patients had a CVA.
I will tell you that, and I want it, for everybody who sees this video to realize that we started with all of our transfemorals under general anesthesia. And so it's been over a process of 300-400 cases before we started transitioning. And people need to be comfortable with the procedure before they move straight to this type of approach. And we became—
Because the patients are awake.
That's right.
Exactly.
Because the patients are awake, your team needs to be very much in gel. And now, after having done over 900 cases, almost all of our transfemorals are done minimalist. But that's not how we started. And as the people who see this video also see the procedure that's going to be highlighted here, you have to remember this is something we've been doing for 8 or 9 years. We don't necessarily advocate going straight to this procedure if you've only done 5 or 10 cases. You really need to have this under your belt. You need that protection of general anesthesia. Vasilis, tell me what your thoughts are about this. I've noticed that in those patients who have general anesthesia, you sometimes see a larger change in blood pressures. You go up and down a lot more rapidly, and that flux is more. In these awake patients, we seem to have a more consistent blood pressure. Tell me, what are your thoughts about that? Is that what you experience also?
Yeah, that's definitely been our experience. And some of the hypothesis behind that is that when you give heavy sedation or general anesthesia, you can knock a lot of the sympathetic drive out,
right,
which is intact in the awake patient. So a lot of the minute-to-minute variations, which the patient is taking care for you,
that's right,
it has to be managed by the anesthesiologist. So we tend to have these peaks and valleys.
That's right.
And then we're wondering is this a complication? Is there a problem? Do we have to pause to get the blood pressure down? Do we have to pause to get the blood pressure up? And it seems like we have less interruptions doing this with conscious sedation.
I agree with that too. What is the role of transthoracic echocardiography in minimalist TAVR? So one of the controversies about minimalist TAVR, I think that people have talked about nationally and internationally, is the assessment of paravalvular leak after the valve implantation, and also the placement of the valve in balloon expandable valves for the use of echocardiography for that placement. So we agree with that, and we, after having done many hundreds of cases, we use TE for all of those patients. And as we transitioned to minimalist TAVR, it took a learning curve for our echocardiography team to be very adept at looking at transthoracic in the windows that we needed. So the goal is to perform the same quality echocardiography of transthoracic as we did for transesophageal, to be able to assess the long axis, short axis, and the apical views, to give the operators, the surgeon and the cardiologist, very good confidence that we're seeing paravalvular leaks. So I think that you have to have a team that is facile in transthoracic echo as they would be in TEE. So I think it's an incredibly important tool, echocardiography, for the assessment and placement of the valve. And I think that's something that if you do not have that in place, I think that the minimalist TAVR becomes a little bit more of a challenge, because you may impinge on some of the quality that we don't want to lessen. Vasilis, what are your thoughts?
So the role of echocardiography in TAVR is critically important. I think everybody agrees. And how to transition from general anesthesia with the transesophageal echo probe in place to cath lab awake patient, don't have the probe down, because we've had some elderly patients with the endotracheal intubation and then the esophageal.
Sometimes strictures,
they have problems, or they have limitations, or they have delayed swallowing, a lot of problems with malnutrition afterwards. So how do you make that transition? And there are several things that we've done. And the understanding of TAVR today is much different than when we started back in 2007. Right now, the planning is so detailed that we've done our transesophageal echo at baseline if we haven't done a CT scan for annular sizing and for deployment angles. And certainly, in some patients, we've done both.
That's right.
And so we have the plan as far as understanding what valve size and where to place it. Now, the combination at that point of angiography and transthoracic echo then becomes very powerful, particularly in an experienced operator's hands.
Right.
And you can make a correlation between the two during the implant, whether it's for baseline assessment, whether it's for
intraoperative,
placement of the valve, or whether it's for post-assessment, right? Because we talk about doing angiography afterwards, looking at the AR index, and also correlating this what we're seeing on the transthoracic echo. And I think when you say to yourself that you have very good planning and you have good windows for transthoracic echo, and you have an experienced team that can correlate well with the angio, that's very powerful. And we've seen no difference when comparing to our group that had this done completely under transesophageal echo.
So, I can't remember a patient that we've looked at with transthoracic preoperative echoes that we've excluded from minimalist TAVR. Do you remember of anybody? I can't remember of anybody.
With transthoracic?
That's right. And so I will also mention that, we're really fortunate to have Stam Larakis, who is the director of imaging for the Valve Center, who has really been the champion on allowing us to do this and has really taught the other echocardiographers how to do this. So we're indebted not to just the two of us doing this, but really we have an imaging component which we think is integral to a successful minimalist TAVR program. Would you agree?
I do. I think that when you look at the three components of echo, planning, placement, and then assessment for complications, which is what paravalvular leak could be under a complication or untoward event. So we're looking for effusions and ruptures and so forth. The guys the echo team has done extremely well, and I think one thing that Stam Larakis has done very well is to try and understand placement of these valves by making it very simple, by looking at the aortic shoulder of the valve and lining it up with the tips of the leaflet.
That's right.
Instead of to line up a virtual area of the annulus in the mid portion of the stent. So that has allowed us to transition very easy to do the same thing with the transthoracic echo.
That's right.
We can identify the aortic shoulder very well because it is not shadowed by the calcification of the aortic annulus, and we can line up the leaflet tips with it quite well. Once you start looking below the aortic valve, things do shadow out even with the transesophageal echo. So using this, we've really championed moving forward. And then complication assessment, like you talked about with paravalvular leak, but all the other complications are very easy to identify with the transthoracic echo.
Yeah, just don't compromise quality.
Absolutely. So the question becomes for minimalist operators is, what do you do about bailout? What do you do if you have a complication? And this is a question we hear over and over again. So one of the things that Vino and I did before we started minimalist approach is we looked back at all our transfemoral data.
That's right.
And we looked at how many times we had to bail out to cardiopulmonary bypass. At the time we had done 300 or 400 cases, overall transapical and transfemoral, and we had not bailed out once to a transfemoral.
That's right.
For transfemoral TAVR to cardiopulmonary bypass. There is some data out there that also suggests that salvage surgery on patients that are inoperable tend to have, as you would imagine, is you change the patient from elective to emergent, that's already very high risk or inoperable, the outcomes and the morbidity associated with that, the mortality morbidity with bailout surgery is not ideal. So it goes back to two concepts. One is pre-procedure planning, and if you think that you're going to need a surgical bailout, this is probably not the patient you should be doing in the cath lab. And the second thing is management of complications. So what type of complications? Annular rupture is one. Pericardial tamponade is another. Vascular complications and coronary occlusions.
Right.
So we do screen our patients very carefully for coronary occlusion.
Right.
And so the low-hanging coronary is not ideal for the cath lab. And balloon valvuloplasty with aortography, honestly, if you are concerned about it, is a very good indication of whether you're going to have one, because it's not just the height of the coronary, but it's also the root, as well as the length of the leaflets, the calcification, and the sinotubular junction. So those patients we tend to screen out. For pericardial tamponade, I think it's very easy to treat in the cath lab.
That's right.
Vascular complications, we do have a coated balloon if we need to stabilize things, but most of our repairs, I would say, other than vascular cut downs, which can be performed in a cath lab as needed, can be managed.
Yeah, there's been less than 1% chance for us taking a patient from the cath lab to the operating room for a vascular cut down. And so it's been quite small, the need for that.
Vino, do you want to comment as a cardiac surgeon and tell us a little bit about what you think the role of bailout surgery here is in these type of questions. You know, I left out annular rupture because that's really in your domain.
Right.
And you can talk a little bit about salvage of that and overall salvage and bailout strategies.
So yeah, this is something surgeons ask me also across the country when we talk about minimalist TAVR. So a couple of caveats and I'll put out there. Number one, at Emory, and every program will have its own special needs and wants. For us, we currently do not have, as you know, perfusion in our rooms. So we do not have perfusion in a cath lab with us. We also do, however, we do have a balloon pump in the room, obviously, and the catheter is available for that. You mentioned the Coda balloon also. So some of the bailouts that I think of from a surgical end point of view is I can't put somebody on bypass here in the cath lab. And as you and I looked at our data, we were okay with that because out of all the cases we've done, there's been one patient that we've put on bypass, and that was a patient that had a coronary occlusion that occurred, and that patient was taken to the operating room. And that's the only patient that's gone on bypass through the groins for a transfemoral.
And this occurred after we started our minimalist experience.
Absolutely, and this occurred almost after 150 minimalist TAVRs that we had done. So the bailout that we have for our patients, knowing our experience at Emory, in those patients that are high risk but yet operable, we would take those patients to the operating room if need be, okay? And if it was a root rupture, we would take that patient to the OR and operate on them. If they're inoperative patients, then the heart team has to decide that there's nothing heroic going to happen because those patients are inoperative, and we make that decision ahead of time after especially a big family meeting. So the bailout is, we found very a discussion amongst the heart team of what it's going to be, how it's going to work with operable and operative patients, but we found it to be quite satisfying that we've had an extremely low bailout need. And so I'm quite comfortable doing stuff in the cath lab as we've discussed already.
Yeah, I mean, I think that a lot of this, there's precedence. You know, coronary angioplasty, coronary stenting.
Right. There's an evolution to the whole process.
Absolutely. You know, whether you should have a surgical block on standby or not, and whether you can do standalone.
But it's also your comfort level within your institution.
Yeah, and also based on your experience.
That's right.
I think if you have a good experience, that speaks to less likely to need bailing out.
I agree with that.
And I think if you're still learning the procedure and still not sure if you're going to need bailout, probably you're not ready to do minimalist.
Yeah, well, at least you're ready to maybe start some parts of it, but not full Monty.
Exactly.
All right, great. So Vasilis, let's talk a little bit about what it takes for a team to go towards a minimalist TAVR. Okay, so one of the things is that you have to have a very integrated team, and so luckily for you and I, we didn't start our minimalist TAVR until we had 300 or 400 patients under our belt, and that's a combination of TA and TF. What I think that's required is, first of all, you have to have a team. You have to have a team of nurses in the cath lab that are comfortable giving medications. For us, as you know, we have no anesthesiologists in the room. And so we have a very unbelievable group of nurses and techs who are circulating with us, who are giving medications, i.e. sedation medications. They're comfortable managing levofed if we need it. So that team has to be first put in place. If you have a team that's there, and that team has to be experienced with, let's say, balloon valvuloplasty. We believe that you have to be able to know how to do valvuloplasty. Remember, they're looking at somewhere around a 12 or 14 French sheath. Everybody in the room is comfortable with pacing. So that's probably one of the first components of it. Also, the other component we've talked about, I know, is percutaneous closure. So if you're comfortable closing 14 French sheaths and you start moving into, let's say, the XT device up to 18, 20 French sheaths, then that should also really gel well, and it'll be a stepwise progression towards a minimalist TAVR. So when I start thinking of what it takes to be a minimalist TAVR, you have to have some experience under your belt. It's hard to say exactly how many patients, but a very comfortable situation where you're comfortable with the procedure itself, you're comfortable with percutaneous closure, you're comfortable with balloon valvuloplasty, and most importantly, in my opinion, you have a great team of nurses and imaging people who complement what the surgeon and the cardiologist do for the transcatheter valve. What would you add on to that?
Yeah, I mean, we definitely have to say the techs in the room, because we have people that are crimping for us. We have people that, you know, you put out your right hand and the appropriate instrument shows up.
Right.
And you can move things along even in a situation where you have to speed up or to slow down.
Right.
And a lot of times the experienced team also can pull back, slow down, and change course or change decisions to end up with an incredible outcome.
That's right.
And I think those are the type of team dynamics that you're talking about. So
I agree with that.
I agree with all that too.
Yeah, that's perfect.
So what is the evidence?
Right.
That this works or that we should be doing it. And so we started down this road with the idea of really streamlining the procedure because we thought it would be better for the patients. We thought it would be better for our throughput and for our hospital. So let's talk about how it impacts our patients. And we have described this in the literature, as have a few other centers, particularly Alain Cribier's group from Rouen, France, who published in JACC Intervention 150 patients. We published a comparison of 70 patients done in the cath lab and 70 patients done.
And I think John Webbis presented some stuff also.
Absolutely, on the 3M approach.
That's right.
With early discharge, and all of them kind of pointing in the same direction that says that it can be done safely. In our experience comparing patients that were done completely minimalist to patients that were a fully dressed up procedure, like the way that all of us used to do it, general anesthesia, transesophageal echo.
In the hybrid room.
In the hybrid operating room, absolutely.
That's right.
With the Swan-Ganz catheter and Foley catheters and all the lines and so forth and perfusion backup, we found that at 30 days there was no difference in mortality, there was no difference in paravalvular leak, there was no difference in where you sent the patient home or whether you sent them to a rehabilitation. And we actually found that our ICU utilization went down and our length of stay went down.
Right.
I mean, the other thing is the economic impact. Maybe you want to say a few words.
Yeah, I think so. I think that, you're right. And to reiterate what you said, and you published, in JACC Intervention, is that the goal is to provide the patient with the same quality, but a easier procedure on them. And the cost has been very, in our favor. We are decreasing the cost of, let's say, the hybrid room, operating room, which is a higher cost than is a cath lab. You're decreasing, I think, the ICU stay, which is also very beneficial when you look at the bottom line.
Yeah, we've actually gotten rid of the ICU stay.
That's right. And we would say that in those patients who have no vascular complications and they were not requiring pacing, they generally do not go back to the intensive care unit. They go straight to their private room, which is a great thing for patients and their families. And also it's a mental thing for them. They feel much better about their procedure. But the cost with cutting down a lot of that cost, we've been able to, again, and I think it's important to say without a compromise in quality, we've been able to save, tens of thousands of dollars of additional cost that we no longer have to spend in the hospital. So it's been not only resource utilization, but our overall cost has been improved. Therefore, we're able to get more throughput through our system. And quite honestly, this makes our administrators happy. And it makes us happy. But most importantly, it makes the patients happy. And that's really why we're here. We're here to benefit an elderly group of patients with the least invasive but effective therapy for the management of aortic stenosis.
Well, some of the things that we didn't even mention in the article were time to ambulation.
That's right.
Time to first meal. Time to, discharge obviously was shorter, but all these quality metrics that were not even reported in the paper are much shorter when the patient hasn't had intubation or TE or general anesthesia.
Absolutely agree with that.
And they look very good afterwards.
Yep, absolutely. From a surgeon's point of view, I get asked a lot, how are we moving things to the cath lab and where is that going to go for the future? And to be quite honest with you, I think from a surgeon's point of view, I'm very happy to see this. I think that, first of all, the collaboration that surgeons and cardiologists have continues in the cath lab. There is no separating of the hybrid team that we've put together, and I think that's exceedingly important. And I think that the surgeon thinks of this, or I think of this, as a continuation of our care of patients. And once we work as a team together, we're at the end of the day doing the best thing for the patient. It's the least invasive, yet great outcomes.